Welcome to the deep dive. Today we're getting straight into herpes simplex keratitis, or HSK, using your MSRA revision notes as our guide. Our aim: pull out the key facts you really need for understanding this, and crucially, for remembering it. So, let's start right there. What exactly is herpes simplex keratitis?
Okay, so think of HSK as a viral infection hitting the cornea, that clear front part of your eye. It's caused by the herpes simplex virus, HSV. And the result, well, it can be corneal inflammation, ulceration, quite a bit of discomfort, and even vision problems. The really classic sign, the one to picture in your mind, is the dendritic corneal ulcer. It looks like tiny branches spreading on the eye's surface.
Dendritic ulcer, like branches. Got it. Okay, so what's actually causing this? Which virus are we talking about?
It's mainly herpes simplex virus type 1, HSV1.
Yeah.
That's the usual suspect behind cold sores. HSV2 can cause it too, but that's definitely less common.
Right, HSV1 mostly. And how does someone get it?
It can be through direct contact with someone who's infected. But, and this is really important, it can also be a reactivation. The virus can just lie dormant in your nerves after an initial infection and then flare up later. But that's why HSK often recurs.
Ah, okay, so reactivation is a big factor. What makes someone more prone to getting HSK or these reactivations?
Yeah, several things increase the risk.
Mm.
Having had ocular herpes before is, well, obviously a big one. Also, anything that suppresses the immune system, so immunosuppression.
Makes sense.
Eye trauma can sort of open the door for the virus.
Mm.
And using corticosteroid eye drops is another risk factor because they can dampen the local immune response.
Corticosteroids, interesting. Anything else?
Yes, exposure to UV radiation, like strong sunlight, can sometimes trigger it.
Yeah.
So sunglasses are actually helpful.
UV light, okay. So stepping back a bit, how does the virus actually do the damage? How do we get from virus to ulcer?
Well, the virus, HSV, it enters the cornea, direct contact. Once it's in those corneal cells, it starts replicating, making copies of itself. And that triggers your immune system. The immune response causes inflammation, which leads to tissue damage, and eventually the formation of those ulcers, like the dendritic ones.
So the virus causes damage, but the immune response does too, in a way.
Exactly. It's a combination. Now, if you see something with symptoms, it's not always HSK, right? What else might it be?
Good point. You need to consider other things that cause keratitis. Bacterial keratitis is one, fungal keratitis two.
And importantly, herpes zoster ophthalmicus. That's shingles affecting the eye.
Caused by a different herpes virus, the varicella zoster one.
Precisely. And the treatment's different, so you need to distinguish them.
Okay. How common is HSK? Are we likely to see it often in the UK?
The exact prevalence isn't perfectly known, but the estimated incidence each year is around 1 in 5,000 people. So yes, you'll definitely encounter it.
1 in 5,000. Okay. So let's talk presentation. What does the patient complain of? What are the key signs?
Typically, it's a red eye. It feels sore, maybe like there's grit or a foreign body in there. Vision might be blurred, often quite a bit of tearing, what we call epiphora. And they're usually very sensitive to light photophobia.
That cluster sounds key. Red, painful, gritty feeling, watery, light sensitive.
Yes, and remember that mnemonic: red, sore, light-sensitive eye. On examination with a slit lamp, you're looking for those corneal ulcers, especially the classic dendritic pattern.
And fluorescein stain helps see the ulcer.
Absolutely. Fluorescein staining highlights epithelial ulcers very clearly under cobalt blue light. Oh, and recurrent episodes might sometimes have milder symptoms, just to keep you on your toes.
Right. So if we suspect HSK based on the history and the look of the eye, what investigations confirm it?
Well, a clinical picture, especially with a slit lamp exam showing a dendritic ulcer, is often highly suggestive. But for confirmation, especially in, say, atypical cases, or if treatment isn't working, you can take corneal scrapings.
Scrapings for what?
To send to the lab for viral culture, or, more commonly now, PCR polymerase chain reaction, which detects the HSV DNA directly, much faster.
Slit lamp first, maybe PCR if needed. And management, what's the approach?
The absolute key thing is an immediate, urgent referral to an ophthalmologist. This needs specialist management.
Okay, urgent referral. What will the ophthalmologist likely do?
Treatment revolves around antiviral therapy. That might be topical eye drops like aceclivir ointment or oral antiviral tablets, sometimes both, depending on how severe it is. Supportive measures are important too, lubricating eye drops for comfort. Corticosteroids might be used cautiously to manage inflammation, but only under specialist supervision and usually alongside antiviral cover.
Right, antivirals are the mainstay. What about the long-term outlook, the prognosis?
It really varies. Depends on the severity, which part of the cornea is involved, and how quickly treatment started. With prompt diagnosis and the right treatment, most cases can be controlled well, and you can minimize complications.
There's always a but, isn't there?
Well, yes. Recurrences are common, unfortunately. And repeated episodes, or severe initial ones, can lead to long-term problems like corneal scarring. And that scarring can permanently affect vision.
Scarring leading to vision loss. What other complications should we be aware of?
There's quite a list, unfortunately. Besides scarring and vision loss, you can get corneal thinning, sometimes called keratoconus, though that's technically different. Also, abnormal blood vessels growing into the cornea, that's neovascularization. Increased risk of secondary bacterial infections because the cornea is compromised.
And the recurrences themselves are a complication, I suppose.
Absolutely. And sometimes the inflammation goes deeper into the corneal layers, causing something called herpetic stromal keratitis, which is more difficult to treat.
Okay, quite a few potential issues down the line. So let's quickly summarize the absolute must-knows for revision. HSK, viral infection of the cornea, HSV1 usually. Think dendritic ulcer.
Key symptoms: red, sore, light-sensitive eye, maybe gritty feeling, tearing, blurred vision.
Crucially, needs urgent ophthalmology referral. Management is primarily antiviral therapy.
And remember those risk factors, previous episodes: immunosuppression, trauma,
Yeah.
steroid use, UV light.
Complications like scarring and recurrence are significant risks, impacting long-term vision. Right. So for deeper revision and practice questions, definitely check out passthemsra.com and freemsra.com. And just to leave you with something to think about, knowing that HSV lies latent and reactivates, how might that change the advice we give patients about managing triggers or recognizing early signs of a recurrence? Something to mull over. Thanks for tuning into this deep dive.